Hello and welcome to Shared Management of Psoriatic Disease and Associated Comorbidities, sponsored by the National Psoriasis Foundation. I'm Evan Siegel. I'm a clinical assistant professor at Georgetown University School of Medicine and a partner in the largest single specialty rheumatology practice in Rockville, Maryland, and primarily a clinician. Joining me today are Elaine Husney from the Cleveland Clinic. She's vice chair of rheumatology at the Arthritis and Musculoskeletal Center. Dr. Husney is a member of the National Psoriasis Foundation Board of Directors. Also joining me today is Joseph Marola, associate professor, Harvard Medical School. Dr. Marola is a member of the National Psoriasis Foundation Medical Board, as am I. As per the requirements of the ACCME, these are our disclosures. And here's what we're going to be doing today. There are 4 modules in today's program. The first one relates to pathophysiology, prevalence, psychosocial impact, and care. The second one is going to talk about psoriatic disease comorbidities. Then we're going to have a presentation on shared management of psoriatic disease, and finally, we should have a very spirited discussion around several cases and the issues surrounding the treatment of psoriatic disease. This has been accredited for 1.5 AMA Category 1 credits. So let's get started right up with our first module. This is going to be a little level setting and some basics about psoriatic arthritis and psoriasis. As you know, psoriasis affects 2 to 3% of the population. It's a very common disorder. We know now that about 30% of patients with psoriasis will develop psoriatic arthritis at some point. That has been confirmed in several studies with slight variations based on the population studied. What's important to note, particularly for the dermatologists on the line, is that approximately 15% of patients with psoriasis will have undiagnosed psoriatic arthritis. So dermatologists are the front line for the discovery of psoriatic arthritis in patients with psoriasis. I often like to say that psoriatic arthritis is an equal opportunity disease. The male-female ratio is 1-to-1, unlike RA, which has a female predominance, and ankylosing spondylitis, which we still feel has a slight male predominance. And age of onset is generally between the 30 and 50 age range, but can be quite variable, and we do see it in the pediatric population as well. How does psoriatic arthritis present? Well, as you probably know, skin disease typically precedes joint disease by up to about 10 years. So once again, these patients are often being seen by their dermatologist regularly and need to really alert their dermatologist as to the onset of joint symptoms or need to be screened for those joint symptoms. About 15% of patients will present with joint disease first. That is the challenge to the rheumatologist, really understanding the patterns of disease that psoriatic arthritis can present with even prior to skin disease. It's important to remember that there's really no correlation between the severity of skin and joint disease. So patients can have very severe skin disease and very little joint disease, or vice versa, a very severe joint disease and only a patch or two of plaque psoriasis, sometimes hiding in places like the scalp. The only thing that's important to remember also is that patients with extreme skin disease, with much more severe skin disease, do have a higher risk of developing psoriatic arthritis. We think that the nail findings are also very associated with a prevalence, a predisposition for psoriatic arthritis, particularly DIP joint involvement, and we think that that may relate to inflammation at the nail matrix related to enthesitis. What are some of the risk factors to keep in mind, especially for dermatologists who are seeing patients regularly with psoriasis? Once again, severe psoriasis has a higher risk for psoriatic arthritis. Interestingly, the location of psoriasis often is associated with an increased risk. So scalp psoriasis, psoriasis in the intergluteal fold, and also nail involvement. So we think that's a very important risk factor for psoriatic arthritis. And patients with significant nail involvement should be screened carefully for psoriatic arthritis. Family history, obesity, and some of these other factors also very important. Where does this come from? What about the pathogenesis of psoriatic arthritis, and especially what we think about now, that skin to joint transition? How does that happen? What's actually going on? So just a very quick overview, helicopter view. So we do know that stressed keratinocytes produce DNA, which is picked up by an antibacterial peptide called LL37. This produces interferon alpha, which stimulates circulating plasmacytoid dendritic cells. Those plasmacytoid dendritic cells then stimulate dermal dendritic cells, which migrate to a draining lymph node locally. In the presence of IL-12 and IL-23, this causes naive T cells to differentiate into either Th1 cells or Th17 cells, leading to the production of IL-17, IL-22, as well as TNF-alpha. So this is significant cytokine production. Those Th1 and Th17 cells migrate back to the dermis, where they stimulate keratinocytes, which again produce large amounts of cytokines, which can then become systemic. That systemic transmission can then move to the synovium, causing synovitis. But perhaps even more importantly, people have looked at the synovial enthesial complex, demonstrated in the top right corner here. Here, there's activation of the innate immune system, and we think this may be very important. Remember that entheses are all in the area of a joint, so there's synovium very close to every enthesial connection where tendon attaches to bone. These are areas of local trauma and biomechanical stress. That biomechanical stress through the innate immune system causes the production of IL-23, which then stimulates these local resident type 17 cells producing IL-17 and IL-22. Those cytokines can then go to the adjacent synovium and synovial space, again causing synovitis locally and then systemic spread of these cytokines. We'll come back to the IL-22 in a second, but also in the bone marrow, we're seeing expansion of Th1 and Th17 cells, but really importantly, also an increase in osteoclast precursors. These osteoclast precursors then can become systemic and move to the joint. In the presence in the joint of TNF-alpha and rank L, those osteoclast precursors become full-blown osteoclasts, causing significant erosion. Going back to IL-22, IL-22 seems to stimulate osteoblast function, and that's perhaps why we see the very classic findings in psoriatic arthritis radiographically of both bone erosion and new bone formation, typical of psoriatic arthritis. But wait, there's more. We also think that the microbiome plays a role, and microbial dysbiosis in the gut causes the production of IL-23 and then stimulation again of Th17 cells and production of IL-17, again producing systemic increase in these cytokines, which can stimulate joint inflammation and erosion. So a very complex pathologic process for what turns out to be a very complicated disorder affecting multiple, both musculoskeletal and other organ systems. What about the clinical features? Well, these are the things that we look for. Obviously, skin and nail disease. We see classic psoriatic plaques most commonly, but other types of psoriasis can be seen. Again, a reason that we may want to be co-managing with a dermatologist, looking at these other types of psoriasis, guttate, pustular, erythrodermic variants. Again, looking at the nails, we see onycholysis and nail pitting. Maybe as much as 85% of patients with psoriatic arthritis will have nail findings. We think probably about 40% of patients just with psoriasis. So again, as I mentioned earlier, a predictive factor of who may develop psoriatic arthritis. We see several forms of inflammatory polyarthritis. There's most commonly an asymmetric form. That's what we look for classically in psoriatic arthritis. Often oligoarticular, but it can be polyarticular. And really, we're looking for DIP joint involvement in these patients, helpful to separate out from other inflammatory arthropathies like rheumatoid arthritis. And in a small percentage, and seemingly progressively smaller, fortunately, maybe because we're treating earlier is the very severe form of arthritis known as arthritis mutilans, which can cause severe destruction of joints in a very short period of time. And needs to be treated very aggressively. This form also has the very highest number of osteoclast precursors that we were talking about before, maybe promoting some of that erosion. We need to think about spondylitis in these patients. Probably about 40% of patients with psoriatic arthritis will have involvement of the spine or sacroiliac joints. Very rare, however, just to have spondylitis. So only about 5% of patients with psoriatic arthritis will have isolated axial disease. And in those, I actually start to think a little bit more about whether this could be ankylosing spondylitis with associated psoriasis. About 10 or 11% of patients with AS will have associated psoriasis. Dactylitis in about 40 to 50%. That's, of course, and we'll talk about that in a moment, swelling of an entire digit, and enthesitis, again, in about 40 to 50% of patients, inflammation at the insertion site of tendon or ligament. How do we make the diagnosis of psoriatic arthritis? Well, these are the Caspar criteria that I hope you're already familiar with. These were validated as classification criteria, but I will tell you from someone who does a lot of clinical rheumatology, I do use these personally as a framework for making the diagnosis of psoriatic arthritis, at least in thinking about patients who are referred to me with the question, does this patient have PSA? And the most important part of this is the STEM, established inflammatory articular disease involving the joint, spine, or the enthesis. So when a dermatologist refers a patient with psoriasis to a rheumatologist, this is really question number one. Is this inflammatory articular disease? If it is, then we use a point system. You need at least 3 points from the list that you see in front of you. You do get 2 points for current psoriasis, but in this criteria set, a history or a family history of psoriasis also gives you a point. We talked about how important the nail disease is, so nail dystrophy is important and gives you a point. Negative rheumatoid factor, the presence currently of dactylitis or a history of dactylitis recorded by a rheumatologist, because when these criteria were created, only rheumatologists actually understood what dactylitis was. I hope that through programs like this, that's going to be much less the case in the future. And finally, radiologic evidence of juxta-articular new bone formation. These are not osteophytes, but sort of ill-defined ossifications. I found that many people don't actually know what these look like, so I'm going to show you in just a moment. Again, the nail changes, and thank you, Dr. Husney, for these images. Nail pitting and onycholysis is what we want to be looking for. And then the radiographic changes on the bottom. You see the typical pencil in cup change. This is what we were talking about earlier, new bone formation. So you can see that distal phalanx has new bone formation forming the cup, and severe osteolysis or erosion of the proximal phalanx here causing the pencil. So that's very classic. On the upper image, and let me magnify that, are these juxta-articular new bone formations. This is something that people aren't that familiar with, even radiologists sometimes, but this is what they look like, these juxta-articular calcifications that are part of the Caspar criteria. We think about psoriatic arthritis in domains. When the ACR NPF criteria were being put together, we realized that there really wasn't a good definition of what active psoriatic arthritis was. Who do we treat? We want to treat patients with active PSA. This is defined as disease causing symptoms in an unacceptably bothersome level as reported by the patient and judged by the examining clinician to be due to greater than or equal to one of these domains. So again, everything in this disease is done in consultation with the patient. And these are the domains, of course, skin, as well as nails, arthritis, dactylitis, enthesitis, and spondylitis. It's important when we think about both diagnosis and treatment to take into account all of the affected domains and which domain is truly most significant for the patient, because that's going to vary from patient to patient. Here's a typical picture of psoriasis, plaque psoriasis. I'm always impressed by the very defined border between active psoriatic lesions with the inflammation, with nearly completely normal skin right on the other side, and of course the significant scale. I think we can all recognize that. Arthritis, we talked about the different forms of arthritis that are present. Some patients can present with DIP joint only or the asymmetrical oligoarthritis, and again, polyarthritis that can sometimes mimic rheumatoid arthritis perfectly. Spondylitis and the arthritis mutilans, all from the Mole and Wright criteria that were published in defining this disease in 1976. Before that, this wasn't even known as a disease. Enthesitis, again, inflammation where tendon, ligament, or joint capsule inserts into the bone. The most common areas that we look for this are at the epicondyles of the elbow, Achilles insertion in the plantar fascia, but many other sites can be affected. I'll show you in a moment. We do know, as I mentioned earlier, that there are these resident T cells that can produce IL-17. This is a picture of fairly significant enthesitis at the Achilles tendon insertion. And these are all the enthesial sites that are measured by various different measurements, the Macy's and the Spark. Not going to focus on those, although you can see how many enthesial sites there are, but I would strongly recommend for clinical practice that you think about the Leeds Enthesitis Index, just 6 sites, the lateral epicondyle, the medial condyle of the knee, and the Achilles tendon insertion. Very easy to examine during a routine clinical examination, pressing on each of these sites, and I would strongly recommend that you document and follow the number of enthesial sites that are active in any given patient. Very easy to do with this LEI. What about dactylitis? Again, this is one of the cardinal features and present in about 40% of patients. We know now from MRI studies that this is a combination of significant inflammation in the joint space with synovitis, enthesitis, there's actual tendinitis, and even osteitis of the bone. This can be problematic. I've had many patients who have ended up in the emergency room for a big swollen toe, and an MRI is done showing osteitis, often mistaken for osteomyelitis, and we've saved more than a few toes by saying that this is actually dactylitis, not osteomyelitis. It can be acute, which is inflamed, significantly swollen and tender, but there is also chronic dactylitis, where the full toe is still somewhat enlarged, but really no longer tendon, and that can be no longer tender, and that can actually be a fairly chronic process. Spondylitis, again, about 40% of patients with spondylitis. You want to think about the eye pain mnemonic for inflammatory back pain that you see here. Insidious onset, pain worse at night and in the morning, age less than 40, improves with activity and not relieved with rest. We want to look at the sacroiliac joints, which can be asymmetric in psoriatic arthritis, so asymmetric sacroiliitis. And really, treatment is just with NSAIDs, TNF-alpha inhibitors, and anti-IL-17 inhibitors are the only interventions that have been shown to be helpful for ankylosing spondylitis and PSA spondylitis. A lot of research going on now in terms of the difference between PSA spondylitis and ankylosing spondylitis stories still being written. These are multiple comorbidities associated with psoriatic arthritis, and Dr. Husney is going to tell us much more about this in a few minutes, but it's important to remember that this is psoriatic disease involving multiple areas with multiple potential comorbidities and complications. What about the psychosocial impact? Very significant, and both the psoriasis and the arthritis has a major impact. When you really take the time to talk to patients, social issues, social participation is often significantly diminished because of extensive psoriasis. Patients are unwilling to wear certain clothing. They're embarrassed by the psoriasis. The fatigue is significant. The disability, particularly with significant hand or lower extremity involvement with enthesitis and synovitis, really can be significant for some of these patients. What about treatment? How do we select a therapy? What's important in selecting a therapy? We want to think about the disease manifestations that are present, so enthesitis, only responds to biologic agents, but not to conventional DMARDs. Dactylitis may respond better to biologics than to conventional DMARDs. And only certain therapies, as I mentioned earlier, are indicated for axial disease. You want to take into account the comorbidities, the method of administration. Obviously, we're constantly thinking about safety, and in this day and age, we also have to think about the economic realities and what's going to be approved. There are several guidelines that are available to help us. The most recent, the ACR-NPF guidelines, but also the GRAPPA and the ULR guidelines back from 2015, all very helpful with pathways of treatment. These are the things that we have available to us. We're very lucky that we live in a time that there has been a tremendous expansion of mechanisms of action, of different agents that can be very helpful for the treatment of psoriatic arthritis. And we now have the opportunity to switch between these agents and try different mechanisms of action. I've outlined here the various different drugs that should or should not be used for spondylitis because, again, there has been a slight difference in the efficacy for spondylitis as compared to arthritis. This is just a good outline of the ACR-NPF guidelines that were published in 2018 or early 2019. Again, many different scenarios are outlined. Probably the most important thing to remember from this is that for the very first time for treatment-naive psoriatic arthritis, the recommendation was to go directly to a TNF inhibitor. And in fact, on these recommendations, it was suggested that a TNF inhibitor, if the first one doesn't work, that it makes sense to go to a second TNF inhibitor. However, if you look at the little disclaimer underneath these boxes, it says that all of these were based on recommendations that were based on low quality evidence. So patient factors and other clinical factors should play a role in the decision as to what goes first and what follows. But if you look at this, there are multiple scenarios that are outlined, almost all of the different issues that you would come across in deciding initial treatment and then ongoing treatment. So if you started first with an oral small molecule, if you started first with an IL-17, what do you do if that doesn't work? And methotrexate was recommended certainly over just NSAIDs in these patients. It has been shown that it's better to treat to target, just like in rheumatoid arthritis. What is the target? We've had several targets proposed. I like minimal disease activity, MDA, which is 5 of 7 of the following issues, basically touching on all of the different domains and physical function. So tender joint count, swollen joint count, less than or equal to 1, the bar has truly been changed, and the bar has been raised for what we will accept as good control in patients. And you can look down these. The minimal disease activity is available on the GRAPPA app, which can be downloaded and can be used just when you're in with patients as well. So finally, I want to say coordination of care is very important in psoriatic arthritis. We're going to talk about this with Dr. Marola in just a few minutes. Rheumatologists, dermatologists, primary care physicians, and even other specialists are all going to play a very important role, and communication is key, and that's really going to be a central message that we're going to drive home as we move forward with these presentations and with our cases. So with that, I want to thank you for joining us today for this module. And I would ask you to please join us in the next module in the series, Psoriatic Disease and Comorbidities with Dr. Elaine Husney. Thank you very much.